If you love the conversations we have here on the Ortho Show, you're going to love what's coming next. Consider this your official invitation to join me on Smart Medicine, a brand new podcast at the intersection of healthcare and innovation. Okay, we want to thank OSSIO as well as Miach, who are sponsors for this very special episode. We are bringing the ACL whisperer back, and that is Greg DiFelice, good friend of ours, who really was one of the first surgeons, first U.S. surgeons to really be a proponent for ACL repair. We talk about his evolution of technique, about how both of us are now evolved to really using biology for our ACL surgical interventions, with specifically the osteofiber anchor, as well as the Miach bare implant as well. It's really remarkable to see the amazing changes that are happening in real time, and we're so thrilled that we're able to share what is really a very important story. Dr. Scott Sigman, please enjoy.
From medical media, this is The Ortho Show.
Hello, world. Dr. Scott Sigman, yes, your favorite opioid-sparing orthopedic surgeon, for another episode of the Ortho Show podcast, where everyone knows we bring you the best of the best. Today, we have a special episode. We're going to get an update on ACL repair with the ACL repair whisperer, the one and only DFO, Greg DiFelice, orthopedic surgeon extraordinaire, sports medicine specialist from this little-known hospital called the Hospital for Special Surgery. Always great to see you, brother. How are you, man?
Absolutely, man. Glad to be here.
We always have great conversations, the two of us, and we become good friends. We travel around. We've done a lot of webinars and stuff together. So we thought we would revisit your remarkable story about the process of ACL repair. This special episode today is powered by both Miach of the bare implant as well as OSSIO with the osteofiber anchor. And we're going to call this episode the DFO Fro Road Show. What do you think, brother?
Sounds pretty good, man.
All right, here we go. All right, so let's go back to the history of ACL repair, because it was an easy journey for you. No big deal. I'm just going to start this whole thing called ACL repair. Everybody's going to accept it, and it's going to be recognized as the next best thing. Not exactly how it played out. When did you do your first ACL repair, and when did you really start talking about it?
Yeah, it was 2008. It took me about 5 years to collect about 20 patients, and I realized that everybody was doing well. They recovered really quickly, and it was durable and effective and far less morbid than the big procedure, which is essentially what we do for everyone. And so at that point, I started to say, I got to study this thing. And I wasn't a big researcher. I wasn't, all of us have our own strengths and weaknesses, and I was never very interested in research. But I realized that if I didn't do any research or follow up on this seriously, that no one was ever going to listen to it, kind of like a tree falling in the forest. So that journey began.
Yeah, so there are a couple things that you mentioned there, which I really want to highlight. First and foremost is that you didn't just sort of crush and just roll into this thing and just start repairing every ACL. You didn't do that many, and you took a long time to sort of evolve and study and watch. And then again, you weren't a big researcher, and so therefore you were going to have to prove it to everybody. But I want to know why. Like, why did you decide to repair that first case when you're talking to that patient? Why did you want to repair that ACL?
Yeah, I will refer folks back to our first conversation in June of 2020. And the story's the same. I was up in the Bronx. I was taking care of a group of people that were socioeconomically deprived. And when you do the big surgery, there's one thing for damn sure, is that you better have a strong support network around you to help you to get through the surgery, because it is mentally and physically and all that's tough. And it takes resources. And the folks up at this hospital where I was working at in the Bronx called Jacoby, they didn't have the resources. And so I noticed that they weren't getting as good of outcomes as I was used to when I trained at special surgery. And that prompted me to say, man, maybe we can bring this surgery down a few notches. And it was because of the technological advances at the time, suture anchors and stitchers for the rotator cuff. It allowed me to sneak into the knee and essentially do what I called the rotator cuff repair for the knee. And and I followed them, and it worked, and it was durable, less invasive, and I said, man, we got to study this and get it going.
I love it. So it was based out of necessity, okay, because of the environment in which you were working. So you figured, let's try to reduce the injury to the tissues. Maybe we can get these patients to heal faster. They're not going to have as much physical therapy as we would, typically get. So resources were limited. So you came up with this strategy. And then I think it's also important is that, and you brought it up, that the shoulder instrumentation had evolved tremendously in the arthroscopic space. And so that what you did was you borrowed that technology from the shoulder, cross-pollination, if you will, and then used that and brought it over into the knee. And so, again, for all of our listeners that may not be up to speed on this, why is it that we were told for the first 20 years of our careers, Greg, that ACLs wouldn't heal?
Well, look, back in the day when they didn't have the technology, all they had was a knife and some catgut. They would cut the knee open with a 10-inch incision. They'd stitch it together no matter what it looked like because they had no idea what it was going to look like because they didn't have MRIs. And then because they were so nervous that it wasn't strong, they would just put them in a cast with their knee bent for 2 months, which, as we all know in the modern day, makes us cringe because it's a recipe for disaster. 100% of the people were miserable. 100% of the people got stiff, and it took them forever to get better. And then 50% of them failed because they were stitching together ligaments that didn't have a chance in hell of healing. And so they made the fatal mistake. They concluded that the ACL can't heal because of bad blood supply, and that's what we've all been taught, and that's still in every textbook out there. And what I would say is that is hogwash. That the ACL can absolutely heal, but it just depends on how you tear it, right? And so if you avulse it from the wall or you tear it in a less devastating way, then you may have a chance of getting those fibers to knit back together. And the one that I chose to work on originally was the type 1s and 2 tears in the top 25% of the ligament, because the whole bottom part of the ligament is intact and the blood supply is coming up. And we can just stick it next to the wall like we do for every other soft tissue in the body. When we stick soft tissue next to bone, we know it's going to heal. And so why not do it in the knee?
And I love it. I mean, nowadays, like when I'm going in and I see one of we call them a Sherman type 1. Basically, it just means that the ACL's pulled off the femur bone, and you see these blood vessels and this robust amount of collagen. Like they're like 95% of the ligaments just sitting there. It's just not working, but it's sitting there, and it's like, why are we taking it out? I mean, we joke around about it now. Oh my God, 30 years ago we opened them up, we put them in a cast. I mean, you think about it. 20 years from now, they're going to look back and say they were cutting out people's kneecaps and sticking it inside of their knee to do an ACL reconstruction. That's barbaric, right? So we're in the process of the evolution of watching that happen, which I think really is fantastic. All right, so let's go. Let's speed up here a little bit. So so you've done your first 20 in the first 5 years. You're catching all kinds of gripe from everybody, even your partners at your local hospital are giving you a hard time. We don't have to go into all the details, but just to say that, but you still push through because your data was so good. And then really after that 5 year period, that's when you really started evolving and like lecturing and sharing your data. And then, so let's talk about the evolution now of what you're doing now compared to, let's say, the first 20 when you first started.
Yeah, so I'll roll back just a smidge there. Is that at first I started off, it was just a dual suture anchor repair. One set of non-resorbable stitches for each bundle, anchor into each bundle origin. There we go. Then I started adding the suture augmentation with the tapes, and we studied that and showed that wasn't it was effective and it wasn't deleterious, and we advanced from there. And so the technique has slowly evolved, and I went from 20 to 50 to 100 and advanced up through 500, etc. I think at the last time we spoke, it was 300, and now it's been 17 years and over 700 patients. But the one thing that I wanted to do as I got better and better and better at this was, and as the technology of the biologics started to come around, right? I mean, let's be realistic. It's been the past 5 or 7 years that the biologics have just kerplunked right onto our laps, and now we've got a lot of things that can help us to heal. And so the things that's really evolved in my last 2 or 3 years is that I had a biologic evolution, and I started that off with myself and a few other surgeons. We developed a suture called Active Braid that's half collagen and half synthetic. So it's absolutely strong, but the body grows right into it. And that was the beginning of it. We were started in animals and worked it up. And finally, that was brought out, and it's just carried by Zimmer. I use it for every single soft tissue procedure in the body. And then I said, well, why the heck don't I use the most biologic anchor in the body, right? And so OSSIO, I learned about OSSIO, and I like the idea of biointegratives rather than bioabsorbables, right? Because the one problem that I had with the bioabsorbables when I used them was that sometimes they'd make cystic cavities where the anchor went in. In addition, that they're not very strong, and so when I tried to put them into the bone, sometimes they would strip, as we all know, and that's very frustrating. That usually prompts you to go to a PEEK or a plastic implant, which is going to leave the problem of plastic that never goes away. And so if there was something out there that could just integrate into the bone without going through that lytic phase, that would be a perfect application. And I found OSSIO, and I've been using OSSIO for the past close to 2 years now, and it's everything they say it is. It's strong, it integrates, it gives me perfect fixation, and I have nothing but good to say about it.
All right, so then we're going to move on into the bear too. So first and foremost, I love that. I like to say the first 20 years of my practice, I was a mechanic, right? We had screws, we had plates, we had drills, and everything was a problem, and you just fixed it with a mechanical fix, a carpenter, right? The last 10 years, I've really become a biologist, really trying to incorporate biology into the process. All right, so Ivan Tornos, I know you listen to every one of our podcasts. We love you, brother. So Active Braid is a great suture, big fans of it. And we're going to talk about OSSIO and Miach, and Ivan, you're going to probably buy both of those companies. We'll see. But at the end of the day, Active Braid, you're loving it for the collagen, for the repair. You then moved into the anchor, which is going to be really, truly resorbable. I mean, I find, one of my fun things for OSSIO is, don't settle for metal, right? We used to put metal into everything now, but they have these biointegrative. So literally the anchor will become bone. Over 18 to 24 months, you literally go back in and look, the anchor is completely gone. Compared to so many of the bioabsorbable implants, correct me if I'm wrong, where literally sometimes you go in at 2 years to look at your bioabsorbable implant, you could literally remove it and go and sell it on eBay. It looks so good, right? So, so it's like, so literally we do want these things to go away, but we don't want them to be cystic. We don't want all this crap lying around in there. You want it to actually be bone. So that's literally, the process. So for me in particular, that was a huge advance for ACL repair, switching over to the osteofiber, implant as well. And you've done more than I have at this point, and you're satisfied with the outcomes and how it holds and its fixation and all that good stuff.
Yeah. Hey, Scott, when did you start? When did you jump in on the repair train? Because I think 5 years ago you weren't doing it, right?
Yeah, so I jumped in. So our journey sort of came together on ACL repair when the bear became commercialized. And so I had done I dabbled into, a little bit of ACL repair. I had a couple of patients, but I was still sort of, seeing more younger patients. I was a little concerned, and we'll talk about your data about the age range as to where there was some discrepancy as to the results. But really, it was about 2.5, 3 years ago when the bear became commercialized. I then went all in because I felt like not only was I going to give a mechanical fix to the ACL repair, but I could add the biology. And then once I did that, Then I was still using metal for these little buttons that I was using, the old
Yeah.
technique that Martha Murray and they had all developed. And then, McNulty and the crew from OSSIO were knocking on my door, and I was like, all right, this seems reasonable. And they're like, yeah, Defoe's using it. It's having great success with it. And I said, let's make that transition. And I've never looked back. I love the anchor.
Yeah, it's very addictive because you just see how well people do, right? I mean, once you take that leap and you see the difference in recovery, it's hard to justify doing a reconstruction for everybody. And then, people can gravitate towards me and look at my data and show that it's durable, it lasts, and we can go from there. But the other major player in my biologic evolution, and remember, if you recall, I had this algorithm, which everyone who does repair has, and it was originally when I first started, it was reconstruct everyone, and then I switched to repair what I can and reconstruct the rest, and then it was repair what I can, augment what I can, and then reconstruct the rest. And then now finally, I have repair what I can, bear what I can, what I can't repair straight away, and augment also if there's missing tissue, and then only recon as a last resort. I call that my preservation first approach. And I actually trademarked it, so that and $5 in New York will get me a cup of coffee.
And you've got your hashtag save the ACL mug right behind you, so you get a cup without having to pay for the cup. I love it.
Exactly. And so that's my approach, right? It's a bespoke treatment for ACL injury, patient-centric. And the one thing that I added about a year and a half ago was I asked myself, frankly, I said, why am I not trying the bear? Of all the people out there who've got experience with ACL repair, nobody's got more than me, right? And I said, there's a bunch of tears that I would love to be able to repair, and those are the mid-substance ones, right? Because it's not everybody we see is a huge athlete, right? And so sometimes you want an alternative, and what that alternative was for me, it was to try and get that mid-substance crowd. And so I started about a year and a half ago, and I've repaired close to 40 mid-substance tears now, and I use the bear, and lo and behold, they've all healed. And I wasn't expecting that, to be honest with you. I was a little skeptical, and I frankly admit it, because I was all in on my proximal repairs, right? And I thought that it was too far of a reach to get those mid-substance. And then I started to do it. I talked to my patients. We made a shared decision. And sure enough, now I have a whole lane of my highway, my treatment highway, that uses the bear to treat mid-substance tears.
You and I are completely aligned in that regard, and I've done about the same number of mid-substance tears as well. So give us the number. I mean, what's the percentage of people that have an acute, remember, it's an acute ACL for our listeners, right? If you have a chronic ACL tear that you tore 10 years ago and you're going to walk into our office, we're not going to be able to do an ACL repair. It's just the tissue is typically sort of eroded, gone, it's not there. So we're talking of your acute, so go ahead, you're going to say you got a time out. How far you want to go?
I'm going to correct you on that one because, again, it just comes from my experience, right? People come into me, the ACL's pulled from the wall, it's stuck to the PCL. I had a guy way in the beginning, he was 11 years out from his tear. He bucket handled his meniscus. And I said to him, hey, your ACL's loose. And he said, oh, yeah, I tore it 11 years ago and I was too scared to have the big surgery, so I just left it. And now I bucket handled my meniscus. I said, I have to go in anyways. You want me to try and cut your ACL off your PCL and see if I can reattach it? And it worked like a charm. The guy's
all right, so I'll give you the caveat, okay? I will say this. If you have tissue, you need to have ACL tissue to be able to consider a repair. And more often than not, the chronics usually don't have that perfect scenario that you were just describing. But, if it's there, you're right. And honestly, the collagen from the bear implant, again, I'm not commenting from the FDA, probably helps the meniscus to heal as well, to be honest, but that's a whole other story too.
Yeah, absolutely. So I've used the bear on those chronics too. So in my practice, right, which is a very busy ACL practice, as you can imagine, as more and more and more people hear about the reality that they don't have to have the big, huge surgery. right? And they come in and they are massively intrigued by this possibility. Is my practice, I have the rebar approach of preservation first. I repair close to 50% of them, to be honest with you, 45 to 50% of the patients. I bear about 10 to 15% of my patients. I augment, and that's using a smaller graft and repairing if you have tissue loss, about 20% of my patients. And I only reconstruct 1 out of 5.
Yeah, we're pretty similar there too, I gotta say. I mean, I've sort of drunk the Kool-Aid at this point. I've been watching the patients. I see the follow-up. The failure rate with incorporation of the bear in particular actually is very promising compared to past, if you look at the reconstructions, and we'll talk a little bit about that. I just want to throw in a couple comments. One of the comments I always get about the OSSIO anchor in particular, this is a new thing. Do we really have proof that it works? It really has been used for over 6 years in the foot and ankle space, in particular with over 45,000 implants. So it's a safe and effective FDA approved anchor that really behaves very well and is really indicated for fixation within the cortical bone. So without adverse reaction. So great implant. We're both happy that we're using it. Okay. So now it sounds like, so 4 out of 5 are getting some sort of a biologic repair event rather than undergoing, reconstruction. There are a couple of things that have happened for the bear implant in particular, which are impressive, and actually also for OSSIO too. Now, OSSIO just had an improved indication as well, but the bear implant is now approved for both partial ACL tears as well as nearly the entire pediatric population. So from the age 2 and up, basically, you can now incorporate a bear implant for ACL repair. So that's pretty impressive too. What are your thoughts about that improved indication?
Well, look, one thing I want to roll back and just not get people too excited about is that I may be 75 to 80% of some kind of biologic or repair. But remember, my practice, I've been doing this for 17 years. People fly in from all over the world for me to repair their ACLs. And the surgeon out there who's just starting in this space cannot expect to be able to do that kind of stuff. I mean, you have to respect the fact that it takes a technical set of skills to be able to do. You have to be able to do a sound repair before you can add the bear. Like, you can't completely depend on the bear and then expect that to magically heal everything. So it all goes hand in hand. And so I do quite a bit of repair, and then a lane is bear. For other people, when they start repairing, they may want to use the bear for all of them because it helps to gild the lily a little bit for them. And so everybody's journey into ACL repair and these biologics is going to be a little different. And the message that you and I are here to share is that, look, me being kind of the guy who started a lot of this, and now me converting over and joining with Martha, who was the other person who did a ton of research on the bear implant. We've got that experience that we can share. Now you've got your experience, and everyone can start realizing that, holy crap, there's articles coming out from all over the world corroborating the fact that repair works. And maybe, just maybe, this thing is actually going to supplant a lot of people getting reconstructions. Because I think that there are a huge number of people out there who tear their ACLs who aren't super high-level athletes. And by the way, you and I both know that the things that we're doing, repairing and bearing and all that stuff, that's not like a substandard approach. I don't give people that approach because I don't think they're an athlete. I give them that approach because I think I can heal their ACL and they can get back to doing whatever the hell they want. Because you and I have both done it on reasonably high-level athletes. And as long as you can heal the ACL, it's great, Trust the body, give it a chance, help it to heal, and we're on our way. And
but it's a great point. I mean, look, I've done this ACL repair with a bear on a 14-year-old with wide open growth plates using the OSSIO anchor, which is beautiful because I'm skipping the growth plates now altogether. I've done it on a 65-year-old master equestrian that was having instability getting on and off the horse that felt like she was not going to want to stop that. And so everybody's idea of return to sport is different. If you're an 18-year-old who's competing for, Spain in the World Cup, you're gonna have a high demand, but you might be 45 as an accountant that wants to continue skiing and playing golf, or you may be 60 years old who's a master skier. So, we need to tailor the needs of our patients to the types of injuries that they have. And I agree. I think over time that this is not going to become the exception. I think it's really going to become the rule. There's some great data that's coming out now too, and I'm glad you touched on that. At the Academy this past year, the ACL registry data was shared by Jacqueline Brady, the first 100 patients that were included in the Bear ACL registry with a 2% failure rate. I mean, that is outstanding compared to the literature for ACL reconstruction. Or even if you take a look at Martha Murray and the initial data that came out of Children's, the FDA pivotal study where there was a 13.9% failure rate in the pivotal study, but still that compared to, previous, literature as well. So we've put this Bear implant has been commercialized. It's put into the hands of master surgeons, and we're seeing results that are really quite remarkable. What are your thoughts about that?
Oh boy, I got a lot of thoughts on that, man. Because look, I was just listening to a presentation a short time ago where the guy up on the stage was your standard reconstruction guy, one size fits all, everybody gets a reconstruction. And they only have one metric. Did it fail? They don't talk about the morbidity. They don't talk about the fact that if you look at ACL outcomes in young people, there are a lot of problems. There are well documented of people who develop chronic anxiety, irreversible weight gain, sedentariness, and all sorts of problems that go along with it, not to mention the high failure rates and contralateral failure rates. And our answer is, well, let's add the LET. Now we're going to do a slope changing osteotomy, and we're just going to keep making the surgery bigger and bigger.
Mechanical fixes, right? Exactly. Those are all mechanical fixes, not biology.
Right. And no one will talk about the fact that this is a ridiculously morbid surgery, and and let's not forget the post-traumatic arthritis of 10 to 40% at 10 to 15 years. That's not a big deal if an old steamer like you and me busts our ACL, but it's a huge problem if you start off at 15 and now you're 25 and you got arthritis. As we've all seen, it's absolutely heartbreaking, right? And now you've got these options. Martha puts out her data. I forget what it was, a 14-ish%. No significant difference, and everybody gets on her because the patella tendon has a 5% or whatever it is. It depends which study you look at. And nobody ever talked about or looked at and said, hey, if she had a 14% failure rate, that means 86% of the people skipped a reconstruction.
Great point.
Right? Nobody ever looks at that. And I'll tell you from 17 years of experience is when the people do have a failure from these repair procedures, you go into the knee to see.
It's like a primary ACL.
Looks completely normal.
Yeah.
And so I would love to get the pediatric doctors on this conversation, right? I remember I had a 12-year-old girl from Chicago flew out, open growth plates. Parents were really nervous, and she wasn't a super athlete. She was very anxious. We did the repair. I didn't see her again for 6 years. She was playing all sorts of sports, and finally somebody took her out in a soccer game, and she retore it. I went in and looked, and it was a completely normal young knee. And we did a recon, and she moved on, and that's a total success in my world. But they don't think about it that way. They just keep doing bigger and bigger and bigger surgeries.
Yeah, there's a few thoughts come to mind, which are really paramount in my brain. First and foremost is for these Bear patients in particular, when they come back to see you at 1 year or 18 months, more often than not, they'll look at you and they'll just say, like, my knee is normal. Like, my knee feels normal. Now, I've been doing ACL reconstructions for 35 years. It's very rare that a patient that undergoes an ACL reconstruction will tell you my knee feels normal. What they'll tell you is, yeah, you did a good job, doc. I got back on the field and I played for a couple of years, and then you look at the x-ray. There's metal everywhere. There's tunnels and holes in the knee everywhere. And so along with that, I posted on LinkedIn, I don't know, it was probably about 6 months ago, the evolution of ACL. What's the future of ACL surgery? And I put up an x-ray. And it was a post-op x-ray from 6 months after the surgery. And you couldn't tell that anything had been done. We used OSSIO anchors, so you can't see the anchors. There's no tunnels because we don't drill tunnels anymore. And it's a normal x-ray post-ACL surgery. I mean, how? And 50,000 people looked at that thing within a week. They couldn't believe it. So again, thoughts?
Yeah, I mean, look, I was, like I said, I've been doing this for a long time, and all of my stuff started with multi-ligament knee injuries, right? So I started off in that trauma world where I saw god-awful injuries. Dropping a motorcycle at 75 miles an hour and spinning your knee out. And that's where I really started repairing ligaments. And I remember back then, if you think it's bad, as you know, for just how bad an ACL looks when you got all that metal in there, you remember what they look like back when they have a multi-ligament, three of the ligaments, right? And I showed a very similar x-ray way back in 2005 of what the modern day multi-leg looks like. And it was just one little button, right? And so I'm totally with you on that point, because all of these techniques that we're talking about and these biologics, I've used extensively for multi-legs too. And just yesterday, we repaired a bunch of MCLs, so ACL MCLs from skiing, and we did osseo anchors, active braid suture reinforcement, and get them up and move them right away. Repaired the ACL and the MCL, and they'll be mostly healed by the time that they would just be getting out of the brace and getting their ACL reconstruction if they did it the old way, right? So it's great stuff, and I think that we're really onto something, and we just got to keep talking, right? I mean, I've got all the bruises and the scabs and the stab marks from being the first guy, and we're past that now, and I think people are really starting to embrace this and go, hey, maybe there is something to that. And so it behooves us to be thoughtful about it, to train on how to do it. And that brings up a couple of things for Miach. The bear bashes or, regional meetings. I know you're doing one in Austin, correct?
Austin, August 24th with Sean Kelly as well. And so, yeah, Miach and OSSIO coming together to be able to share this sort of, concept, I think is really cool.
Absolutely. And we're doing one in San Diego maybe 2 or 3 weeks afterwards. And if people can get to these regional trainings, I'm opening up my OR. If people want to come and watch me do it, I'm happy to share all my experience, my data, all that stuff. In fact, Miach actually just asked me if I would be their national strategic advisor because of all my experience. I'm super excited to work with them. So we can try and do this thing right? I mean, you got to train, you got to learn the techniques. And, obviously there's some tricks of the trade that we need to go. But if we do it right, I think we can really, really help the patients so that they can have a patient-centric approach to these injury patterns.
And, we're dealing with, decades and decades of prior education and treatments, right? And so to sort of change the paradigm, it's not an easy process. It takes time. The good news is for our listeners that are out there, both patients as well as maybe doctors that haven't done a lot of this, is that it's not really a hard operation. I mean, there are certain operations that you have to learn, like, they're complex. You got to go to, you got to spend a lot of time. You spend months to really practice and get there. But everybody's already got, if you're doing ACL reconstruction and rotator cuff repair, you've got the skill set to be able to do this ACL repair with this implant, and it's pretty straightforward. It's just not that hard of an operation to really learn. The learning curve is really not very steep.
Yeah, it's funny. My patients, I see quite a volume of ACLs each week. And so I go through this conversation constantly. And the whole rebar concept, I see the light bulb go off in my patient's head. And literally 95% of the patients look at me at the end of the conversation. They go, Doc, can you tell me one thing? how come everybody doesn't do it this way? And I say to them always, I say, I've been trying to figure out that forever because it makes such perfect sense to you and me, right? And the analogy that I use now for my patients, I say, because I like to cook a little bit, right? And I say, imagine if you would a French chef who uses the sous vide, technique to cook meat. And they put it in the bag and they put it in the water on low, and then they leave it there for three hours. It's about the easiest thing on the planet to do. And to be honest with you, it works really well. And you take it out, you sear it on each side, and you got a perfectly medium rare steak if that's the way you like it. Now imagine that French guy goes down to Texas and walks up to a guy standing next to a big old barbecue and tells him, "Hey, I think you should, dunk your meat in the water." And imagine the reception he's going to get. It's probably not going to work out. And so, it's like that for anything. It's painful to
Innovation innovation requires courage, and there's very few people that are willing to take on the establishment and try to revolutionize and change the way in which we do things. And more often than not, you're met with exceptional skepticism. But what I like to say now of 40 years of innovation in my practice as well, we're kindred spirits in that regard, is the more people tell me that my idea is a bad idea, I am more convinced than ever that it's a good idea. And so again, for our listeners that are out there, it is okay to try new things. It is okay for you as patients to seek out doctors that are innovating and changing the way in which we do things. I think that there's tremendous evidence that continues to build for this type of ACL repair. For example, the Moon study that's going on right now with the gold standard with the bone patellar bone graft versus the bare implant is very promising. The registry data that's coming out, the preclinical studies that were done for the bare implant in particular, which demonstrated reduction in osteoarthritis, that would sort of be the holy grail, right? That if we could do these repairs and 30 years, look down the line and see that these patients did not develop arthritis. So a lot of great things that are happening.
Let me add one thing there if I could. I know we're running short on time. I think that, talking about innovators, the one thing that's critical is it's the responsibility of the innovator to try and show that the new way or alternative treatment protocol is better, right? And it's good to follow your patients. And I am really, really proud to say that my group, from the DiFelice Foundation for Orthopedics, DeFo for short, which I started about 5 years ago. My group is just putting out our 10 to 15 year follow-up on the very first 20 patients we did, and no arthritis.
How many of the 20 do you have?
We've got like 16 of them back. So two failed early, technical issues. One didn't follow any directions, actually. We lost 2 to follow up, and we got 16. We've got x-rays on a huge percentage of them, and it really shows nothing, no arthritis. And so I think there's one guy who probably has a bit of arthritis, but he was the very first one. He had a multi-ligament knee reconstruction on his other leg. And he got that at 43, and now he's almost 60. So yeah, we got a little, Kelligren Lawrence grade 3 in that guy's knee, but everyone else, it looks like a pristine knee. And so that's the amazing thing, is now we have some actual clinical data coming out showing that saving this ligament is reasonable to predict that we are going to actually minimize the arthritis, which is not what we see with the recon, as you know.
Yeah, no, this has been fantastic. DeFo, appreciate you so much for your innovation, your willingness to put yourself out there. And really, you have really been pivotal in revolutionizing the way that we think about ACL repair. I want to thank our sponsors, Miach and OSSIO, for their generous contribution here today. I would say that I am thrilled with the opportunity to be able to use also Active Rate as well. So we appreciate that as well from Zimmer. So those 3 things coming together to truly revolutionize how we're thinking about ACL repair is really fantastic. So we can't thank you enough for your time.
Thanks for having me. Great talking to you.
We'll see you on the Defo Fro Roadshow, my brother. We'll see you soon.
Take care, man.
All right. Dr. Scott Sigman, hashtag follow the Fro, host of the Ortho Show. Till next time. If you love the conversations we have here on the Ortho Show, you're going to love what's coming next. Consider this your official invitation to join me on Smart Medicine, a brand new podcast at the intersection of healthcare and innovation.